Hello, and welcome to the Hatch Training Blocking AMA. My name is Abby. I'm a content writer for Hatch, and we're excited to have you here today.
Yes, and my name is Kirsten, and I am part of the training and research department here at Hatch. Let's dive in.
So today on our agenda, we are going to be defining AMA and the importance of blocking AMA. We'll talk about identifying AMA and solutions. We'll go through recommendations and considerations, and then we'll end with a close.
Wonderful. Well, before we dive in too much, we're going to take a moment to just talk about what is AMA. So AMA stands for Against Medical Advice. And this is a common term that's used in the healthcare setting to describe when a patient or a client decides to engage in an action that goes against the advice of the medical team overseeing their care. It's most commonly used to describe when a patient is leaving treatment, when the medical team recommends that the patient continue services. So the whole goal of this training is to really help reduce clients engaging in any behavior against medical advice, particularly against leaving services, and helping to kind of address those, important reasons as to maybe why they're doing that. So
let's talk about how to understand why a patient might go AMA. There are numerous factors that have been reported that can increase the likelihood of patients leaving against medical advice, such as family members not being involved or informed, distracted or unorganized onboarding process, poor communication between staff, family, and referral sources, poor treatment planning. So staff should ensure to create a strong treatment plan to reduce the risk of AMA. Nobody's telling the client no. Nobody's asking them not to leave or saying like, hey, maybe it's too soon. But this typically will work best once that rapport has already been built with the client. There might be negative influence from peers on the outside or on the inside. They might be leaving to quote unquote fix things on the outside with relationships, with work, etc. There might be a lack of health insurance. There might be substance use going on. There could be alcohol-related disorder or mental health problems, unhappiness with the provided care, financial constraints, lack of clinical improvement with the received treatment, dissatisfaction with the hospital environment, discontentment with the behavior of the medical staff or social circumstances, absence of advanced medical service, lack of coordination of care, and they might be upset with the length of stay. So those are just some of the factors that contribute to why somebody might leave against medical advice and things to keep in mind as we continue on through today's training. Kirsten, anything to add or any thoughts on any of those?
Yeah, I mean, I think you had a really comprehensive list, which was great. To me, I really see two different categories here. The first category being external factors, things related to like health insurance, maybe, pressure from peers outside of the healthcare facility, maybe things going on with the family, maybe they're stressed about work, paying, maybe they're stressed about time off of work. So I think there's like external environment that we're really limited in our ability to control as healthcare professionals. And then there's the internal component. So, being dissatisfied with care, not having a good onboarding process, not communicating well or building rapport with, team members that are in the healthcare facility. That is stuff that we can control. And that's where I would really focus our attention. If someone says, I'm stressed about work, you don't just say, okay, well, I can't do anything about that. I think that there's still some deep diving that we can look into, and we can do some advocacy and problem solving with the client to see how we can support them. But I do think it's really important when someone is contemplating leaving or even just expressing frustration, because sometimes it's not, just I'm done, I want to go. Usually it starts off with being a little frustrated, maybe comments like, I don't feel like I'm making any progress, or I don't know what I'm doing here. I'm tired of being here. There's these kind of like little subtle things that happen. And probing a little bit of like, tell me a little bit more about that. What's going on? Where is that coming from? And kind of seeing, is this internal? Is this a program issue? Is this a staff or maybe they're having rapport issues with the other clients that are engaging? Maybe they trying to figure out what's going on there, or if it's something external. I think that, from that list, I think that's kind of like step one, is really looking at, okay, here's this reasoning. What's the level of control that we're going to honestly have over it, so that we can then, we'll need to come up with a strategy as a larger team later, and we'll talk through those steps. But I think that that's a huge step one. And really, I would strongly encourage all healthcare facilities, if you're not, to really you should always be evaluating when clients are going AMA, and really evaluating, how often is that internal reasons, and how often are those external reasons, and really looking at that, and helping support staff in engaging in those conversations and finding their ownership. And, as a program or as a staff member, how do we address the ones that are in our control? So that's what immediately comes to my mind. And I know we're going to dive in more, in terms of next steps later, but that's, thinking about internal versus external is the first thing that pops up for me.
Yeah, I love that. Thank you for kind of separating those into categories. And it's a great point. And yeah, we're going to go further into how do you identify these really early on so that we can decrease the chances that they happen.
Absolutely. Well, on the next slide, I wanted to talk a little bit about statistics. These are not, guaranteed. We always like to bring in stats because we're data driven here at Hatch. And I just want to be really cognizant that this is not, 100% of the time, if someone has these things, it's guaranteed they're going to go MA. But there is data that says that at minimum, there's a correlation here. That's something worth us noting. So what does the data say? Well, individuals that engage in alcohol and opiate use are more likely to go AMA within the first 10 to 16 days. That's really important info for us to know that, I think a lot of the times facilities are like, okay, we just need to get them in the door and then it's all going to be okay. And that, the data would say that we really need to kind of keep our eyes and ears peeled, especially during those kind of first 2 weeks. Especially when you're going to go like residential treatment, when you're away from home in a new environment, there's a lot of new people, your entire routine has changed. Maybe you're in a different state or a different city. It can be really jarring. So I think it's really important for staff members to recognize, just because you got them in the door, that's not where the work ends. That's where the work begins. So being really cognizant of those, first 2 weeks is super critical.
That first impression is so important.
Yeah, absolutely. And, I think it's easy to think like, well, their first day is the first impression, but let's remember that we usually, especially for residential treatment, we've got a lot of staff because it's 24-hour care. And so the first 2 weeks is probably when they're going to be, that's how long it probably takes to meet everybody on the team, and so those first impressions are continuing, even though, maybe you're a therapist and you work Monday through Friday, 9 to 5, you're like, I've been seeing this person for 2 weeks now. There might be a night BHT that, hasn't seen them yet. And it's been a week and a half. And this is the first time they're interacting with them. So first impressions, that's a great point. And sometimes programming changes week over week. So usually within those first 2 weeks, you've probably experienced most things that the facility has to offer at least once. So it's a good mental note. Staff sometimes maybe don't realize what's new because they're working there every single day, but it could be new to a client over the first 2 weeks.
Mm-hmm.
Next one is individuals engaging in meth use are at higher risk in the first 21 days for AMA. So again, same thing. It's not guaranteed, but it's definitely something for us to just be mindful of, that there's just a higher chance of them going against medical advice. People entering treatment for the first time, I think that, again, we need to be really cognizant of the work doesn't end just when we get them in the door. And I think that that's critical for us to be really cognizant of. Treatment can be really scary and a huge adjustment for people. And just because maybe someone has acknowledged that they need help doesn't mean it doesn't mean that it's going to be smooth sailing after that. And first time treatment, I mean, I think that there's a lot of the word that I've heard used before is hidden curriculum. And what I mean by that is that there's a lot of stuff that you don't know until you know it. I know that sounds silly, but there's a lot of things about treatment and just the way that facilities operate that you wouldn't know that that's how they operate unless you either work there or you've been there as a client. And so that first time can just be really jarring. As an example, the going through the luggage and going through all the whatever they brought with them, right? So all the staff know that's part of the protocol to ensure that people didn't bring any substances or any weapons or, any contraband that they're not supposed to have. But for someone who's new to treatment, this is the very first time they might, and the facility may or may not share that information prior to them arriving. And so they might not know that a bag check is going to happen until literally their bags are taken from them and a check is happening in front of them. And that could be really jarring and surprising. And so that's, something to just be mindful of, that all of these experiences are brand new for someone for the first time in treatment, and can be really intimidating. People who are in detox, detox is just such a brutal experience on the body for most individuals. And so it's not uncommon that we see people leave against medical advice, partly from the physical impacts. And then of course, obviously the psychological impacts that come with participating in detox and just the intensity. And obviously we're so close to the last time there was use. And so it's really easy for people to want to go back out into their substance use. Prior AMA, and this is always kind of a tricky one for me, because I think we need to balance that. You're nervous about people entering for the first time. Now you're telling me I also need to worry about people that have been in treatment before. It's like, okay, so do I just need to worry about everybody? I mean, on some level, yes, I would say yes. I think everyone has the opportunities to leave treatment. And I think that if you're in recovery, it's easy to come up with a million reasons why you should leave treatment, or why it would be easier to leave treatment. Doesn't mean that they're going to leave, but it is something to just be mindful of. If they've left prior, there is a chance that they will leave again. Between 1% to 2% of hospitalized patients leave the hospital against medical advice. So this is for people that are, maybe in the hospital setting as they're detoxing, waiting to get transferred or something like that to a different program. You usually see about 1% to 2% of these patients leaving the hospital and never even kind of rather making it to, some hospitals have like a residential behavioral health unit, and then some will just transfer to a different location. About 1% to 2% don't move forward and end up leaving prior to getting transferred anywhere else. Other variables that come into play regarding people going AMA is just being younger in age. Adolescence is typically more common. Individuals identify as males, membership into a visible minority group. So racial minorities is a common one, as well as people that are part of the LGBTQ plus community. Lower socioeconomic status, absence of health insurance is a huge one. Just the fear of the cost of services, substance use, psychiatric disorders. So and that's something why it's so critical. There's a huge movement towards co-occurring programs to be able to address both psychiatric needs and substance use needs. And some of that in part stems from this realization that it is really hard to just manage one or the other, and that we need to manage both. So psychiatric disorders, we have seen a trend, when those services are not offered to support them, we see an increase in going against AMA. And urban residency is another common one that we see. So those are some of the kind of the top stats that we see. Like I said, we've seen correlation. These are not causation. It's not guaranteed, but definitely something to be mindful of. Abby, anything in there that you think is surprising? that you want to just take a second to pull out here, or anything that you just think is really important to kind of drive home?
I mean, I think, yeah, what you said in the beginning of like these statistics are just helpful to know, but everyone is at risk for AMA. So these help break down like things to look for, but we're going to move into the next slide, which is identifying the risk for AMA. And I think this kind of helps us go into, okay, now that we know all clients are at risk for AMA, how do you start to determine who is going to be at a higher risk versus a lower risk? And so we have some questions we're going to go through that you can ask. So a question might be, how do clients detail their history? Are they going into detail about their past with substance use and what that's looked like? Are they being really short with you and not really giving you a lot of information? Because if that's the case, that can kind of show you that they aren't really interested in being here, which again is going to increase the risk of AMA. Are they humble, or are they presenting really beaten down and just upset with themselves in the situation that they're in? Asking, have they left treatment before? How many times? Why? What were those circumstances? What's their reason for being in treatment now? Is it because they chose to be there? Or is it because they felt like they were forced to go to treatment from a family member? Are they dictating? Do they say things like, I have to use my laptop every day in treatment, I need to have my phone? That could be a flag of, okay, this person, again, is coming in already not wanting to cooperate, or already coming in wanting to set their own rules, which could be a risk factor of, them not wanting to be in treatment. Are they resentful? Are they just telling you what you want to hear? These can be really helpful starting points to determine how this client is coming into treatment and allow you to gauge what they're starting off with. So what are you going to be working with? And, if they're answering all of these questions, and they're upset, they have an attitude of, I don't want to be here, I need to be using my laptop and my phone, then you can start off the process of knowing and working with the staff to know, like, okay, this person is probably at higher risk for AMA because they're exhibiting these things, they don't really want to be here, they have this type of attitude. So there are warning signs that might indicate high risk of AMA. These are clients who report little to no problems, clients who have co-occurring disorders, clients who isolate a lot, they're not spending time with staff or other people, and clients who are externally motivated, and clients with significant cultural differences. So those are other things to be aware of when you are assessing risk of AMA. So after you ask these questions, kind of looking into, who is this person? What are they coming to us with? And it's important to block AMA because it could be the difference between life or death for a client. So, these are really important things. They're easy steps that you can take to start setting up a successful treatment and stay for your client. Anything to add, Kirsten?
Yeah, I mean, I think, I imagine some of our viewers are like, well, when do I gather this info? Do I just ask around? And I think a lot of the questions that you have here to kind of help people, a lot of those questions will probably start to be addressed during your biopsychosocial, during that first initial assessment period, when clients get, admitted into the program. And then, I think kind of ongoing through groups or through individual sessions with their therapist, or even just touch points with their nurses. And, I think it's totally okay to say, hey, you're new here. This is my first shift working with you. I'd love to get to, know you better, hear more why you're here, love to connect with you. How are you feeling? Is this your first time? How are you settling in? Have you made any connections? It's totally normal and okay. And a great way to show interest. And if there isn't rapport, build rapport with clients. But I think I think that your facility will already have natural opportunities like the biopsychosocial groups and stuff like that to ask these types of questions and start to get a sense for these things. And then I think, the next step is staff kind of taking that extra step to really connect and engage with new clients, or maybe clients that you see that are struggling. I don't think that any of these should be particularly shocking to anyone, that, a client who isn't communicating with us a lot, maybe a client that's isolating, who isn't engaging. It's not, I don't think that's a surprising warning sign of potential AMA. If they're not building any relationships with anyone, why would you stay? Why would, if
Right.
imagine yourself in that situation. Like I wouldn't want to stay in a facility if I didn't like anyone, or if I wasn't building any connections. That doesn't sound like a good use of my time. We're all busy people. So yeah, I think just being cognizant of your role at the facility, and if you're going to have these opportunities, and if not, how can you be a part of the team to create these opportunities to check in with clients and address any concerns that they have? Because I think, even you could be the maintenance person. I mean, you could be anyone, someone that maybe isn't necessarily considered part of, then you might not be the therapist that's doing the biopsychosocial, but you can still build a rapport with a client and potentially flag a concern for the clinical and medical team. So I think everyone has a role to play. Some of them are kind of formal and kind of set in stone, and some are going to be a little bit more fluid, where it's just, hey, I just want to get to know you because you're here and I work here, and I want to get to know everyone. So
yeah, I think it's all about awareness, right? If you have a role to play of just being aware of the people who are at the facility, and there's so many things you can take note of. I think it'd be easy to just be like, oh yeah, they had this attitude and I'm not going to make note of that, or they don't want to be here and I know that and I'm just going to move on. But these are such important things to just be aware of and be keeping track of and be talking to the staff about, because just a conversation or awareness can really help to lower that risk. And I think it's something that can be so easily missed. And so that is the purpose of going through all of this, to just show you how, like, there's so many opportunities to identify somebody who might be at risk for this. And there's so many opportunities to say something and to make a plan and to just lower that risk again and again.
I think you bring up real quick, you touched on such a great point. I think it's so easy. You said it's so easy for, to just kind of ignore it and move on. And, I see that happen a lot, and I get it. The healthcare workers that are at these facilities are doing important work, exhausting work sometimes, especially if you're, personally impacted by recovery. And you kind of read through this list, is the client kind of beaten down? Are they resentful? Are they dictating? It sounds like it might potentially be, a difficult client for some people. And it's easy to get frustrated and be like, you know what? I don't want to deal with this, or I'm frustrated, or they're just so negative. They're, all they're doing is complaining about the program or whatever. I want to focus my energy on those that are not. And so I think it's important to really check in on ourselves if we, if someone is not engaging or is isolating or is really struggling, and we are not, as healthcare professionals, not taking that initial step to really build a relationship and try and understand that, maybe doing some check-in with ourselves of where is that coming from? Are we a little frustrated with this person? And remembering that at the end of the day, we might have some clients that are a little frustrating, or maybe that we don't totally get along with, but they still deserve this treatment, and we should still engage in blocking AMA because that's what's best for the client. That's what's going to help them to be successful. Ultimately, there's only so much you can do, and clients are still going to choose to leave, and they have the right to. But don't just kind of put your hands up in the air and be like, well, they said they wanted to leave, so I'm over it. They've kind of been frustrating. Let's really try and find the root here. Treatment is going to be hard for a lot of people at some point, at least. And that doesn't mean that we don't still do everything we can to support them and help them get the help they need.
Yeah. Thank you. Thanks for adding all that. Very helpful.
All right. So now we're going to talk about some tips for identifying reasons behind a client going AMA. There's numerous ways that you may attempt to find out why the client's going AMA. Your technique will most likely vary kind of based on the state that the patient is in. I don't mean, if they're in Utah or California, I just mean like the rapport that you've built, the length of stay, kind of unique factors regarding their treatment. So some potential ways to identify the problem: engage the client in a discussion away from other patients to reduce social pressure and increase privacy. This is huge. it is so tempting sometimes when a client is frustrated, or maybe you're frustrated with them, to just try and say, what's going on, what's happening. Maybe you're in a group setting. That's a lot of pressure for your client. So make sure to mental note it, and touch base when it can be a little bit more private. Also, you don't necessarily need to gather the entire team to do this check-in. Not Social pressure is not just from fellow clients. It can also be from the team, and you will need your whole team to probably assist this person, but that doesn't mean that the whole team needs to be standing there questioning the patient of what's wrong, what's happening, what's going on. So let's find, maybe one person that has a really good rapport, and maybe two, and talk and give that client a little bit of privacy, and they might open up more than, if a whole panel of teammates are asking what's going on. Gather info from other staff and documentation regarding issues mentioned recently. Are there any issues with housing, issues with medications, cravings, interpersonal issues with staff or with other clients? Any concerns regarding discharge days? Document, document, document. I mean, I think we say this in almost every single training, but I'm going to continue to say it. If it's not written down, it didn't happen. And in times where clients are potentially engaging in AMA, it is critical that our team documented well in advance. And so, when a client is expressing a frustration, doubting treatment, doubting progress, concerns about something that's going to happen once they leave, that is so critical document, so that when these things come up, we can look back later and say, you know what, the last 3 shifts, they have mentioned, not feeling confident about going back to live with their parents. They're feeling, like they might need a sober house or a transition before they make that move. They don't know if it's going to be good for the recovery. Hopefully we've already taken action if they've said it 3 times, but that's important to be able to document and say, oh, this came up multiple times, or every day at 7:00, they start to get frustrated and antsy. That is something for us to document. So, talking to staff and then reviewing documentation is critical. People rarely leave because of what we are doing. Instead, they're usually leaving because of what we aren't doing. And that's in part, you should be able to find that out with staff and documentation. But I think also asking, what's missing? What would you like to start seeing? Or what haven't you seen that you'd like to see from us? And that can be stuff as simple as just not communicating timelines of things. Maybe we're working. So as soon as someone enters the program, we should be talking about discharge and, what it's going to take to discharge, roughly when they will discharge, what will discharge look like. And staff members get busy. And so maybe we haven't communicated that, but we're doing it, kind of on the back end, but maybe we haven't communicated that with the client, and that's causing some anxiety, and they're getting frustrated, and they're like, they aren't doing anything to help me. Maybe you are doing stuff, but they just don't know it. And so communicating what you are doing is going to be critical to building that trust. I think there's a lot of times where we do a lot of stuff behind the scenes, and we always have our client's best interest at heart, but they might not know that. And they might need us to just be a little bit more explicit, or be really clear, or talk through the next steps, or have an opportunity to ask questions, because this is their first time and they don't know, or they're stressed, or, your facility does things a little bit differently than what they're used to. So I think over communicating and giving opportunities for clients to ask questions and touch base can really help to alleviate some of that fear that they might have that something isn't getting done, or, that we haven't thought of something that maybe we just haven't communicated that we thought about it with them. Next one, a lot of people go into treatment not believing that they need the full stay. Sometimes the mindset is, I only need detox, or, the program is 60 days. I could totally do that in like 45 because, I've got all this stuff going. And, I think a lot of people think, the program is, we say it's a 90-day program, and it's like, oh, that must be if you really need a lot of help. I don't need that much help. I don't have that much problems, or I don't have that much going on. So I'll probably only be there for 60 days. That is something that we see a lot, and it can be a huge hit to pride or hit to ego if you do need the full stay. And I think normalizing that is so critical. And it's not about, who has more problems or who, was in a worse state. It's just maybe there's different areas that we could focus on and grow in over the length of that recommended stay. So that's critical. I think maybe that's a conversation to have right at the beginning of, what do you anticipate? What do you know about our recommended length of stay? How are you feeling about it? To make sure that there aren't any of those attitudes where people are just assuming, that's if you really need help and, oh, I only will need half the time or 3/4 of the time. When maybe you recommend everyone to have that time and you're just going to work on different things depending on what the person needs. So that's a huge common one we see that, again, just really communicating explicitly is going to help address. The client might not know how to ask for what they need. This is a common one of, maybe they don't know that there's flexibility regarding a certain program, or maybe they're really struggling with meds and need to make it change, but they don't know. A lot of people, just don't know how healthcare works, or that they can say, you know what, no, I really don't. I don't want to do this medicated, with medication assisting, or, yes, I'm in recovery and I need some medication to assist me and I need help. So often people just think, this is what, the nurse or the doc or the therapist, whoever said, this is what I have to do. And they don't realize that it's a collaborative experience where we can engage in that conversation. So I think just taking a second to talk through, like, you can, we want you to be involved. We want you to be invested. So let's talk about, what do you need, or what questions do you have, or where do we need to make adaptions?
I feel like that one is so related to what you were saying earlier about the hidden curriculum too.
Yeah.
Like, the staff don't realize, like, you have all the information like that your client doesn't have. So they don't, they have opportunities to ask for what they need. They don't know that. And so, making that an easy thing for them to do. It's important.
Absolutely. Yeah. I think so many times people are so terrified to ever question a doctor or a therapist or a nurse. And not that you all aren't the experts, because you totally are. And someone might not know that they can say, I'm really nervous about that, or I don't know if I'm ready for that yet, or are there other options, or so just making sure that it's really clear to clients that that it's a collaborative process, and that they can ask questions and be available. All right. So the last bullet point that we're going to kind of go through is, most people don't want to be in treatment, and they think they can think of better things to be doing. This is another kind of common reason for people on why they might be going AMA. This is one, it is uncomfortable to admit that you need help. I think we all probably struggle with this on some level. I know that there is tons of stigma related to mental health, and especially substance use. And so it's not shocking that there are people who don't want to admit that they are at the point, in their use, that they need that it's really hard for them to admit that they need this type of help, and that they can rather do it on their own, or that they've got other things to do. And that's the addiction speaking, and trying to maintain. So I don't think that's shocking. And I think we've anyone that's worked in the field has probably experienced it. And this is, in part why it's so critical that all of us are engaging in trying to reduce the stigma around mental health, and try and normalize it. And it's not, a moral failing on anyone that they're in treatment, and that getting them well is a top priority, so that they can go back and do the other thing, do the important things that they want to do, the family events or work or school or whatever it is that they think is more important. Their health is a priority. And we know that substance use people die every day when left untreated and unsupported. So I think it's critical that we take a moment to acknowledge, like, yes, we understand that it's uncomfortable to admit that you need treatment or that you need help. It's uncomfortable. And that you might have very important things to do at home or not here. And it's so critical that we get you help so that you can do those other things that you want to do. So those are, just some of kind of the things that tips for how to help people be able to identify why people might be going AMA, and just some things to kind of be mindful of reasons why people might be going AMA. left untreated, clients might not be capable of making rational decisions. And that's why helping them to see that and understand that while in treatment is really important. And providers should maintain that their role is to offer help to the client no matter what, and talk through the options that are there for them. AMA is seen as kind of a missed opportunity where staff usually don't intervene until clients are already 90% out of the door once they've already made their decision. And staff should really be intervening much earlier. And like we've talked about earlier, engaging in those kind of probing questions right at the beginning of why they're in treatment, and every staff member being accountable to building relationships with clients is going to really help us to have earlier interventions, figure out the reasons why people are leaving, and hopefully help to intervene. So let's go ahead. Abby, I believe on the next slide, you actually start to dive into possible interventions for people that are considering.
Yeah, let's talk about interventions. Practitioners are wise to take a calm and reasoned approach to an AMA patient. Failure to do so can spell medical tragedy for the patient and a malpractice disaster for the practitioner. Should a case come to litigation, the outcome will hinge on what was said, done, and documented. As we've said before, documentation is super important. Once you've identified the reasoning behind a patient wanting to go AMA, you can move toward presenting options that will allow them to feel motivated to stay. So we have here some possible interventions. Are we taking a team approach? Did we allow for the staff member with the best rapport to intervene? Should we include the family in the intervention? Should we allow for the referral source to engage in the intervention? And should we offer a peer-led intervention? So this is a group of questions that you can ask with your team once you've identified that this person does want to go AMA. You can get together with your team and identify, okay, what are the best next steps that we can take right now? What is the action that needs to be done? And kind of going through the documentation that you should have of who is the best person to reach out to on behalf of this person. Can the whole team be involved? Is there one person we talked about in an earlier slide, maybe the staff member that does have that rapport with this patient, sitting down with them, taking time to really check in on a personal level and see what's going on, and if there's any changes that we can make and things that we can start doing to possibly allow this person to stay or get them more excited about being here. So, Kirsten, anything to add?
Yeah, I mean, I think, one of the biggest recommendations I would give to facilities is I think that when a client goes AMA, it's so easy for it to become a very emotional moment. I think it's easy for staff to be shocked or to be frustrated, or maybe have their own feelings of like inadequacy or feeling like they failed the client in some way. Often staff members, especially in substance use treatment, often have a personal connection. And so it can be really tempting to hyperfixate on that, and maybe feel like they're failing or have a bit of, countertransference happening where maybe, this reminds them of someone that they love, that they know in recovery or themselves. And I would be really cautious. I think you even mentioned it. It's really important to take a calm, wise and reasoned approach. Mm-hmm. And I think that that's so critical. It's important that we address it and it be multi-pronged, and that we really evaluate this situation and engage in it. But that doesn't mean that we frantically engage in it, or, and kind of recklessly engage in it. I think it's really easy to, in these moments, to get frantic or really emotional, maybe focus on why we want them there, or, how this impacts us. Maybe it's, a bit of an ego hit if this is the first time we've ever had a client leave. And I would just really caution all staff members to really kind of check in with themselves as they're, if they're looped in to this, and as they're kind of engaging throughout, not just during, but afterwards, if they choose to stay or if they choose not to stay, how they engage with other clients. That unfortunately, this is a reality that happens quite a bit in the substance use and mental health field, and while we're going to do the best we can to avoid it, there is only so much that we can control. We can't force people to engage in treatment unless, it's court ordered. And we want them to want to stay and be involved. And so I think just making sure that you take some deep breaths and really reflect on what is best for the client as you engage in these interventions, and what does the client need. It is going to be so critical to doing this effectively, because if we're just acting out of impulse or franticness or out of ego, we could be team approached, but we might be engaging in a way that's going to actually cause more harm, and maybe even just further push the client away. So that would be a note of all of the interventions, things to consider when you're intervening is critical. I would just also reflect on your own, the energy that you're bringing, the emotions that you're bringing, and the motivation that you're bringing, and really make sure that aligns in focusing on the priority that is the client.
Yeah. So once you determine kind of what the intervention is going to look like, what are you going to do next? You don't have to do everything on this list, right? We're determining what is best for this particular client. So maybe it is, okay, we're just going to call this family member and have this talk, and then they're going to meet with the staff member they have the best rapport with. It doesn't need to be every single thing on this list. Again, you have the awareness. You should be having the awareness of knowing what this client needs. So once you've identified the best possible intervention, you can move into the solution. So Kirsten's going to take us through that.
Yeah, absolutely. So we've done a, team approach. We've evaluated past data. We've talked to the client. Now we're going to, focus on an intervention. And really, we want to ensure that our solutions will address the concerns of the client, of the patient, so that they can re-engage in treatment and feel good about it. So, some things to consider when you're presenting a solution is, did we offer a change in sleeping or living arrangements or the situation? If they're in residential treatment, if maybe the issue is stemming mainly from their roommate, and maybe we need to, is a simple room change going to resolve this? And is, maybe we don't want to offer room changes all the time, but maybe ultimately this is worth it. Did we offer them to meet with the medical staff for a potential med adjustment? Med adjustments are huge. And I think that a lot of facilities will, yes, it might be a common symptom, maybe drowsiness or whatever is a common symptom. Doesn't mean that it's not something that maybe we still need to reevaluate, though, to support our client, or at least just have a conversation about med adjustment. So maybe all the medications that we're going to recommend have that, but just engaging in that conversation can be huge. Did we offer a mediation or a change in therapist or a case manager? If there's a staff related issue, and maybe it's not that they don't like the staff member, maybe they just feel they're not being challenged by the staff member, or maybe there's just too much difference culturally with the staff member to where it's becoming untherapeutic. And it's not that staff member is bad. It doesn't mean that staff member is necessarily in trouble or anything, but there's just a better staff member that would support them more. So have we offered that? Have we considered that? Did we offer a PRN for any discomfort the patient may be experiencing? So this is, medication related. Is there something, maybe this is their anxiety is increasing. Maybe their anxiety is increasing at a certain time every day. Or maybe a PRN medication is going to help to resolve some of that, and maybe some, breathing exercises as well. So something worth us looking into. Did we check with medical for the possibility to allow the patient to take the medication that they may have missed a dose of? So this happens sometimes where maybe, this is just kind of one-off where medication was missed or something like that, or, for whatever reason, and this is causing a lot of distress to the client. Have we touched base with the medical team to see what the options are? I think, again, this really kind of focuses on, are we taking a team approach? It is not just the responsibility of the clinical team to manage an AMA. We most likely are going to need to also engage the medical team and see what the options are, and see what we can offer. So is this taking place after hours? Did we attempt to push this to the following clinical day? So, most, especially residential programs, or programs that maybe happen on the weekend. Maybe we don't have a full team on the weekend or in the evening hours. And, we feel like, oh, if, Sharon, the therapist, who has the best rapport with them was here, then maybe she would be able to get to better root cause or help address this concern. And I think just being really transparent with the client about that of, we understand you're frustrated. We understand that maybe right now you're feeling some urgency. And we really think if you could touch base with X person, at 8 a.m. tomorrow, we might have a different answer here. Would you be willing to hold off until morning time? A lot of things can get resolved with a good night's rest. And so not everything, but I've definitely seen it happen before. So definitely something to consider of, is it possible to move this to the next clinical or fully operational day? If all else fails, is clinical willing to negotiate the patient's discharge date? So is it necessary? I think it's important. We talked about how a lot of clients tend to think that, the recommended length of stay is, like kind of worst case scenario. And they might have decided that they don't need that. We might always encourage clients to engage in that full amount of time. And there are situations that come up where maybe this really doesn't make sense. And maybe that extra week really isn't, that there's work where we can recommend them to engage in our outpatient services and they can end a week earlier. And that's going to, help them feel accomplished and feel successful because they did complete it. So this is, something worth just evaluating of, are we sticking to this hard date just because that's what we recommend or because that's honestly what's best for the client? And I think that's, again, going back to not having ego as you're really evaluating these AMAs are we doing what's best for the client or are we just doing, what we've always done or what we're used to doing? So yeah, just some things to consider as you're kind of presenting the solution, making sure you kind of touch base on all these points. As we kind of talked about earlier, it's really important that we're documenting well in these scenarios, not just, for legal reasons, but just also for us to be able to evaluate and just to help reduce them in the future. So Abby, do you have some guidance on what to include in documentation now that you've done a team approach, you've offered some solutions? How do we write all this down?
Yeah, let's go into it. So what do we want to include in the documentation? We know that documentation is super important. So we want to make sure to have the reasons for their decision to leave AMA. Why are they doing it? Your explanation of why they should stay. The patient's ability to make medical decisions right now in the state that they're in. The patient's refusal to be admitted or pursue treatment or request to be discharged. Discussion of the possible risks of leaving AMA. The benefits of the treatment or admission should be explained. The patient's ability to understand and state the risks and benefits of pursuing treatment with the names and relationships of anyone witnessing the discussion. Answering questions about their medical condition, the patient's awareness that they may return for care, and a follow-up plan. Should be really detailed as you can be, is going to be the most helpful when we're documenting things.
Absolutely. And I can't stress this enough. I think it's so critical that we're documenting and really just, I think that, at this point when it's like, no, they're still going AMA, it's so easy for staff to become frustrated and be like, you know what, then leave. And just be really cognizant of that and make sure that you really go through, yes, they're going AMA. Yes, you did everything you can. You're exhausted, you're frustrated, you're a little, upset. Maybe your ego's hurt a little bit, but we still need to make sure that we've really written out and that we've not just written about it in our notes, but that we've actually done it, that we've had conversations talking to the client about, their decision to leave, possible risk factors, the ability for them to come back to the program, next steps, all that sort of stuff. Make sure that that's really well done, because just because someone leaves doesn't necessarily mean that we can't still be held accountable later if something happens right after they've left. And we want to make sure that we've done that and really done right by the client. Even if they're choosing to leave, they still deserve to be well informed of, risks and benefits, opportunities to come back, how to engage in services if they need help. This is a part of the field that we've chosen to be in. And so we need to make sure that we're really giving dignity to all clients, including those that choose to go AMA, by taking care of them, doing a good full discharge process. All right, so we have a list of kind of some do's and don'ts that were taken from the Sullivan Group, just kind of as a guide for the AMA process. First one, don't ignore the patient who wants to leave AMA. If at all possible, stop what you're doing and prepare to address the issue. I think Abby touched on this earlier, and it's just so critical. Don't ignore it. It's easy, especially if you're not, the therapist or maybe their nurse, to say, well, that's not my patient, not my problem. Doesn't matter who you are at the facility, if you're engaging with a client and you have a concern that they might be leaving or they're saying something, do that handoff communication, communicate with the team that's involved, document that information, to really make sure that we're addressing it early, and getting them the support that they need. Do determine the decision-making capability of the patient. Do they comprehend the information and the consequences and understand the risks and benefits of the options? And can they communicate these back to you? This is so critical. It needs to be documented in their file. If they are of sound mind and as they're making these decisions, do they understand the risks or not? This is going to be really critical for us in making sure that we're documenting if we feel confident that they understand the risks or not. Don't blame or berate the patient or anyone else for their desire to leave. Again, like we've said a couple times, this happens all the time in our field. And while we definitely don't want to encourage it, and we want people to engage in services, this does happen. And so shaming people is definitely not going to help or make them want to stay. I wouldn't want to stay somewhere where I just got shamed or beaten down or guilted. Focus on providing support, normalizing feelings of doubt or questioning of treatment, and really, encouraging them. We want to be positive as we encourage them to continue to engage in services, not shame them into engaging. Do apologize if the patient has been waiting or if there have been delays in the patient care process. Apologies are free. Lawsuits cost millions. And I think the other part is just to normalize that we're all people, and your program might have made mistakes. There might have been errors, whether it's on a program level or systems level or individual staff level. There might have been a staff member that maybe they went out sick and no one else picked up the pieces, and so things got delayed. That happens, and an apology will really go a long way. And so just saying, you know what, you're right. I understand that you're frustrated. It's valid that you're frustrated. There were delays, and we never want that to happen. It did happen. So I understand that you're frustrated, and we're really hoping you give us another chance. That's going to go a lot further than just denying it or making excuses. So it's really important that you just own it, even if maybe it wasn't you, but as a team, maybe there was a failure. Let's just own it and talk about how do we move forward. That's going to mean a lot to your clients. Don't just ask the nurse to have the patient sign a generic AMA form and leave. This course of action provides little protection for the practitioner. And, it's just really disingenuous. Really don't just say, all right, fine, sign it and go. We're going to want to engage in some work. It's going to take some time. It's going to take some staff hours. But really having an individualized plan to hopefully address any of the concerns that your client have can reduce those AMAs. So don't just say, okay, great, fill out this form and you'll be out of here. Really engage in a conversation and a process to hopefully keep that person there. Do enlist the patient's family or friends in your attempt to convince the patient to stay, if it makes sense. There might be clients where maybe it doesn't make sense to engage it with their family. Maybe their family has been encouraging them to leave this whole time, and so that's not going to make sense. But if you feel like the family or friends are going to engage in a healthy therapeutic way, absolutely, you can engage with them if they've signed releases of information for them to be involved. Don't express your frustration and anger to the patient. Instead, earnestly convince them that your overriding interest is for their well-being. Make sure that you know that you're on their side against potential threat to their health. Again, so critical. We've talked about this before. Do not let ego get in the way. This is not about you. This is not an example of you as a healthcare worker or your work or your program. This happens, and we're the reason that we're going against this is because we genuinely believe that this client could benefit from our services and our program. And that is the focus, not because, I'm such a great therapist and I'm going to, be really upset if you leave. It's, or I feel like I failed if you left. It's, I want you here because I think that's what's best for you. And let's talk about how you're going to benefit by engaging in this program. To document the patient's informed refusal or crucial diagnostic testing, procedures, treatments in the same detail as you would an AMA. So again, making sure that it's just really clear any refusals or, anytime going against medical advice, we want to make sure that we're well documented. So in case that comes up later. Don't refuse to provide treatment. This could be considered abandoning the treatment. Provide whatever treatment, prescription, follow-up appointments, and be specific in your discharge instructions that the patient will accept. So make sure that, just because someone has said that they're leaving doesn't mean you say, okay, get out of here. We're done. We're not going to provide you your medications or whatever else you need. We're not going to refer you now because we're upset. Your client still deserves to receive treatment and deserves all of the prescriptions and, access to resources and everything like that they would have otherwise. Do document the details of the AMA patient encounter in the patient's chart. Include documentation regarding decision-making capacities, the specific benefits of your proposed treatment plan, the risks of leaving, what you did to get the patient to stay, your compassionate interest in having the patient return for any reason, and then have them sign the AMA form that addresses those details, any witnesses that are family or staff, both. Again, documentation is crucial. If you didn't document it, it didn't happen. Lastly, don't worry about whether or not the patient's insurance will deny payment if they sign out AMA. Their insurance is not your problem, but a malpractice suit will definitely be your problem. This is something that is really interesting. And as someone who's worked in the healthcare field for a number of years, I hear this all the time. This is not true. This is a myth. You often will hear people say, if you go AMA, your insurance will deny payment. More often than not, that is not accurate. That actually very, very rarely happens. And for people that do know that information, obviously, you're going to 100% lose trust and credibility with that patient, especially if they have prior AMAs that insurance has covered. Obviously, if you say that to them, they're going to realize that you don't have the facts. And so you've lost a lot of rapport there. But two, that is not the only reason that we should be engaging clients in services, if their insurance is covering it or not. And that being the sole thing. So I would really caution, yes, it does happen, but it is pretty rare. More than not, insurance does in fact cover services, even if a client goes AMA. So please, please, please do not tell your client and do not use that as a, kind of a weapon or kind of your last ditch effort to encourage them to stay in treatment. We want them to stay in treatment because it's what's best for their health and for their overall well-being, not because of an insurance payment that more likely than not will actually get paid. So that is all I have on the do's and don'ts. Abby, anything to pull out there before we move on?
That was great. Thank you for going through all of those, and the explanation at the end about insurance is helpful. Just helpful tips as we're identifying and going through AMA, because as you said, it's common, it's probably going to happen. And, the more you can keep emotion out of it and document and just be there and take the steps to do what you can do to be in the best interest of your client, the better. So now we're going to move into some recommendations to lower the risk of AMA and things that you can do to create a culture that will diminish the risk of AMA in your facility. So the first one is to improve communication between staff and patient. Always ask for an impact letter to gain some information on the new client. So this is a letter that can be provided by the family members or significant other of the client. This can be a letter that kind of walks through why they're coming to treatment, the history that they have with the family. It can also provide other context from outside people in the patient's life. So that can be really helpful. That can give you a lot of background, a lot of backstory on who this person is that's coming to you, and kind of see it through the lens of somebody that's close to that person. So that can be really, really helpful. Consider the way that the new client is welcomed into the facility. So we talked about this early on in the training. First impressions are vital, and they're ongoing, right? They might not meet a staff member or a person that's in treatment until a few days in. So constantly being aware of how are you welcoming this person? What does it look like as they move through their treatment program? And are there different touch points to make sure that they are being checked in on and they're feeling welcomed and they're feeling listened to and heard? Review the admission process. So we want to know how long is it taking for somebody to be admitted. If it's taking hours, you might want to restructure this because again, somebody coming into the facility, it can be really uncomfortable if it's taking hours. Frustrating feelings can come up. And again, that's going to be something where this client or patient is going to be like, oh my God, why did I get myself into this? This is taking so long. I don't want to be here. So again, what can we do to make it a seamless process and not terrible and not hours of paperwork or hours of sitting through meetings or sitting there waiting and not having anybody help you. So all things to take into consideration when we go through, are we creating a culture where people want to stay here and are having a good time? Because it's hard to have a good time. So that's something we really want to keep in mind. Update old or damaged furniture. The facility should look nice, clean, comfortable. This might be something that we don't really think of, but it's super important because you don't want to be staying somewhere where everything's really outdated, everything's dirty. That's not going to be an environment where somebody feels like they can actually recover or feel better. Also consider color theory. When you're painting walls and the colors that are used, this is so important. People's environment really impact the way that they're able to take in information and feel better and recover. So for instance, greens can invoke a really calming atmosphere. So do some research and make note that it does have an impact on the person's experience, how the facility looks and feels. Secure a strong clinical staff for the weekend shifts. So weekends can be tough, and we want to make sure that, over the weekend, there are people in place that are a strong staff and not staff that's going to just not want to be there because it's the weekend. Again, we want to take this seriously and create an environment where everybody feels like they're being heard and seen and have what they need. Communicate and create a culture where you can identify AMA. This is the purpose of today's training. We've gone through so many different things and talked about the significance and the importance of being aware and being able to see things right away and talk to your staff about what's going on, document things. We've said that so many times. It's so important. These practices can help us continue to create a culture where you are lowering the risk of AMA and you're able to identify these things really early on and make interventions early on. And even when we talked about the solutions, when you intervene, these don't always have to be over the top things, right? It can be something as simple as, okay, we're going to change this person's living situation. We're going to move them to a different room. It can be something that simple. And it's only going to be that simple if you do these things ahead of time to really understand this person and what their needs are. And then finally, customer satisfaction is extremely important and staff attitude makes a difference. So again, we really want to be cognizant of our emotions and not getting frustrated in front of the client, noticing, when staff are getting frustrated, what can we do there? Can we check in with ourselves to understand what's causing us to be frustrated and how can we continue to have a welcoming and warm, friendly attitude to our clients and patients who are in treatment, and it can be scary. It can be not fun. So how do we continue to make sure that we're really welcoming and we're able to create a positive environment as much as we can? Anything to add, Kirsten?
Yeah, I mean, I there was a lot of great points there, a lot of good recommendations. I think there was kind of three things that, just really quickly to pull out. I think reviewing the admission process, I think, is a great point. Most facilities, you usually don't have to complete everything you usually have like the first 24 hours or so to do that. And so evaluating what needs to get done right there the moment they walk in, and what can we maybe push back a little bit, or maybe we build in some breaks, some breathing room, some opportunity to touch base, maybe get a snack, maybe meet some people, maybe do a fun welcoming event. I think that's critical to really kind of look at that process. Does everything have to get done within the first couple hours? Probably not. There's probably some things that need to, and other things can maybe wait until they've had some, a good night's rest or a meal, or a walk, even just like a facility tour can be a great way to just kind of break up, a million questions, or having to sit in a room, while you're going through a bunch of testing and stuff like that. So I think that that's critical. Evaluating the environment, I think, is huge. If, look at the trends. Where are people hanging out and where are people avoiding? Is there a part of your facility that no one ever uses and touches? Why? Why is that? Does it not make sense? Is the function not needed? Is the stuff outdated? Is it overwhelming to look at all the colors or the clutter or whatever? And let's reevaluate, especially for residential programs. It's like you are there all day, all night. We work there, but it's unlikely that our staff live there. So let's really evaluate the comfortability and the functionality and make sure that this makes sense. Yes, maybe we wanted this to be the Zen room, but then we painted it orange, and it's cramped and it's not well lit, and so it is not giving us what we wanted, and so we need to do some reevaluation. And the last one, the satisfaction is so critical. Don't wait until your client is discharging to ask how their experience was. Make sure that your facility builds in regular opportunities to get feedback on their satisfaction or how things are going, or get insights into the program. I think that's so critical. And staff's attitude and openness to that feedback is going to make a huge difference. All of your clients might be really frustrated with X thing that maybe they want a little bit more outdoor time that we could easily build into the schedule. But if we're not getting that info until everyone discharges, I mean, that we might be a month to 3 months behind on taking that action. Versus if we had, once a month or bi-weekly, we had a touch point where people could give feedback, or we had a little box that people could insert that feedback, so just something to consider of, just kind of better addressing these in a quicker manner.
Yeah. Great recommendations.
All righty. Well, now we're going to move on to some mock scenarios. I know we spent a lot of time kind of diving through recommendations and tips and things to consider. So now we're going to just put it to work. So let's go ahead. If you want to kick us off, I'd be switching us over to the next slide, and I will introduce Kate. And we'll kind of give some opportunities to talk through a scenario and people to, take a break and write down their thoughts on how they'd handle it. And we'll come back with solutions.
Yeah, just make sure, be prepared to pause the video, take some notes. You might want to grab a pen and paper if you haven't yet, because we're going to be really diving in and going through some deep scenarios here.
All right, let's meet Kate. So your new client, Kate, is about to check in for inpatient treatment for methamphetamine addiction. She's 23, and this is her first time in rehab. Prior to welcoming Kate, you receive an impact letter from her family that she knows she needs to detox and that this is her main priority. When Kate arrives, her attitude is not friendly. She's adamant about having access to her cell phone and to be in touch with her partner. What immediate actions would you take regarding Kate? Do you believe she's at risk for AMA? Why or why not? What was done prior to welcoming Kate? Take a few minutes to pause the video, consider these questions, and when you're ready, press play to review our debrief. So I know not a lot of info, but just kind of what are some of your initial reactions? Go ahead and pause now, and we'll see you on the next slide when you're ready.
Okay, welcome back to our debrief. So there's a lot of stuff to think through here, but immediate action, we know that Kate is at risk to AMA due to several factors. She wanted to detox. She needed her phone. She's also young. This is her first time at a rehab facility. And these are all factors that put her at a greater risk for AMA. So immediately we're kind of identifying that. We also know that patients in rehab for meth use are at risk for AMA in the first 21 days. So things that we want to make note of and immediately document about this patient. It's also great to know that we did receive an impact letter from the family prior to Kate's arrival. This tells us that the family is involved in her recovery, and we might want to reach out to the family initially to prepare for Kate wanting to leave early. We need to gather more information on her partner's opinion of her recovery, and we need to determine if the partner is a positive influence or a negative influence. If her partner is in active addiction, that is a concern. And if her partner is an ally in recovery, that's helpful. So all information that we can kind of start to gather. And it would probably be helpful to connect Kate with clinical staff that are around her age or personality type so that she can quickly build rapport and start to feel really comfortable. Working with the team who's interacting with her to ensure people aren't being rude or short with her based on her initial attitude at check-in. So, we do know that when she came in, she didn't have a great attitude. We want to make sure that that's not being carried throughout her relationships that she's building with staff. It can be really easy for staff to also have an attitude back or be irritated by Kate. So we want to make sure that that's not happening. Again, taking emotion out of it. It's important that the team is able to remain positive and welcoming, again, to bring down the risk of AMA. We also want to evaluate the company policy about the phone. So is there flexibility here with her having her phone? We know that she immediately said she needs to have her phone. So what accommodations can we make to allow her opportunities to feel like she has that control? We don't immediately want to shut that down or be rude to Kate of like, no, we're taking your phone right now. Because again, this is showing us that there is a risk here for this person already showing signs of going AMA. So can the phone be checked in? Can it be checked out? Can she use it in a certain area, et cetera? Again, what can we do to kind of accommodate this patient to really make sure that they stay the full time and that they are they feel heard and listened to in their time here. So anything else to add, Kirsten?
No, I think you touched on a lot of great points. I mean, definitely, I think it's so easy that when a new client comes in for staff to be really excited. And then when that staff member is not very welcoming, it's easy to get frustrated. And it's easy to build a reputation amongst staff. And it's really critical that we are really cognizant of that. Remember that everyone needs help. And that's why we're here. It's not our job to place judgment. So I think nipping the staff interaction and making sure that that's also not recognized amongst other patients is critical. I think also trying to connect her with other patients that have significant others that they cared a lot about, maybe, and maybe we're a little nervous about at the beginning is going to be really important. In the phone policy, it's so easy. And I've seen this happen a lot where maybe a client comes in pretty, hot and heavy of like, this, I need this thing, or really strict, this is going to be, I have to have the phone or my laptop or whatever it is. And it's really easy for staff to feel tempted to kind of assert some power or authority and say, well, we'll see, or we'll shut that down. And rarely does that work out well for us. And so I think, again, take the ego out of it. And where is the flexibility there? And what's the reasoning behind the phone? Is it to connect with the partner? And, maybe we have a community phone that we can use during X hours that we could provide with. Maybe she's, who knows, maybe they applied for a job, or maybe there's school related concerns that, she's waiting for an email on something. Maybe she's using it to, build connections and potentially leave. We don't know. So I think trying to gather some additional details and try and find some workarounds of, maybe there's some people she's really nervous about losing touch with, that we could have that get, we could give the facility number. Maybe there's a community number that could be used to reach clients. Maybe the email needs to get forwarded to a trusted family member or the partner for, updates about school or work or the apartment or, whatever. So I think there's definitely some digging that needs to get done, but I think really being cognizant of the attitudes and just remaining flexibility and calmness is going to be critical for this one for Kate, for sure.
Yeah, I think it's interesting too. When we first kicked off this scenario, we said like there's not a lot of info here. And
Right.
even looking at what minimal info we had, we're still able to come up with a list of things that we can do, a
Yeah.
list of questions we can ask, and things that we want to make note of, okay, we need to look into this a little bit more. We need to dig a little deeper here. So even presented with a scenario where we have minimal information, there's so much that we can do. So, that's the purpose of this, to really help you to start identifying like something that maybe in the past you would say like, oh, that's, not notable. It probably is notable. Why haven't you asked that question before? And that could be a missed opportunity. So again, that's
Absolutely.
why we like to dive into these scenarios.
Yeah. Yeah. No, you're so right. And I think even just the uniqueness of, like the partner, it's tough to say that this partner could be a great asset to the team at the facility and be really helpful. They could be, really involved in being part of the team that advocated for her being in recovery. Or they could be in active addiction themselves and really struggling and could maybe need some support and resources and not that we would ever encourage our client to break up with someone, but maybe this is someone that we want to distance a little bit in the recovery process, reasonably within our control. So there's just so many factors. We're really going to individualize everything that we do based on getting more info from Kate.
Yeah. Great. So let's move into another client scenario.
Yeah. So next I have Bill. So Bill has been in treatment for alcohol for 21 days. He's 55 and has never been in treatment for alcohol. He has been in treatment for alcohol 2 other times in his life. He's never successfully completed a program before. Bill's family recently told him that in order for him to return home, he has to go to a sober house first for at least 60 days. They did not provide a reason why during the team meeting with staff. Bill immediately became hostile and upset after this meeting and is now adamant that he needs to be discharged immediately. So take some time, reflect on this. I know, again, limited info. We're trying to get you to think and question everything. So take some time. What are some immediate action steps that you would take regarding Bill? What are some risk factors that you've noticed from this scenario? That you need to take into account upon Bill's arrival into treatment and his current progress in treatment. Pause the video, consider these questions, reflect, take down as many notes as you want. When you come back, we'll do another debrief. Can I talk through what are some of our immediate things that pop up? And of course, I'm sure you might even have more.
All right, welcome back. Let's talk about Bill. So for immediate action, we can jump into intervention mode. We can start to ask, okay, what can we do right now to make Bill more comfortable? Connect with his family to identify why they want him to be in a sober house. See what concerns they have about him returning home straight from residential treatment. Potentially facilitate a conversation with Bill and his family to understand their perspective and his concerns a little bit more. See if we can help Bill become more comfortable with this idea, potentially be involved in the sober house selection process if possible. And we want to educate Bill on discharge planning and the process and his level of involvement. Help address any concerns regarding the next steps in his recovery and help build interest in going. We want to provide a really clear timeline of when he will get updates about his discharge and potential transfer so he can feel more comfortable and more involved in that process. And we also want to answer any questions or concerns Bill has about discharge or attending transitional housing. Some risk factors here. He's never completed treatment before, but he has attempted to in the past. So we know that that is a high risk factor for AMA. We also want to ensure that he understood the discharge process from the beginning. He also is an older male client, which we know from our statistics slide earlier on. Older males do have a higher risk of going AMA. So we do want to identify the team member who has the best rapport with Bill and set up a time for them to check in and see if we can develop a plan of action. So you can see here, there's lots of questions and also just making sure that this client feels set up for success in knowing what do these timelines look like? What does the process look like? How can he be more involved so he can feel a little bit more in control of his treatment? Because it seems like from a lot of the things we're seeing here with Bill is he's frustrated with not knowing what's going on, not being involved in what's happening. And especially as somebody who's been in treatment before, he's an older adult, that can be really frustrating. So identifying from the beginning, like, okay, how can we make sure that he feels involved and like his questions are being answered? Again, I feel like this goes back to the hidden curriculum and just assuming that the client knows what's going to happen, assuming that they know how these things work, how discharge work, how check-in works. And in reality, they don't, and they don't know what they're not told. So really creating a space where you can foster this helpful, good communication and conversation where he feels supported and like he is involved in the process. Kirsten, anything to add to that?
Yeah, no, I think you did a great job. I think the other thing, just to be mindful of is I think it would be really easy to pass judgment as a staff member on this situation, whether it's on Bill or on his family. The situation says, that this was the family says he has to go to sober living, for a period of time beforehand. And it seems like, we don't have a lot of details as to why, and that could be startling, unexpected information, even just for the staff members who were engaged in that meeting to be like, whoa, that was a curveball I was not anticipating. And it's easy to get frustrated or feel flustered by that and be like, I can't believe they just threw that at us. And it might be like, yeah, I totally get it. And I don't know why Bill's freaking out. Well, that's a big change, and any change, especially if we're, if this is a new process, maybe this is the furthest along he's gotten in treatment, can definitely be jarring and can have a huge impact on recovery. So I think it's just really what I would really encourage for a scenario like this is just for staff to be really cognizant of their attitudes and their presentation during this time and to be cognizant that it's really not our job to place judgment. With the little detail we have, I understand if a family member chooses to set a boundary of, wanting some additional treatment in place, given that there is a previous history of going AMA and not completing programs. And I think it's understandable that Bill might be a little jarred, a little frustrated, maybe feeling a little attacked. Maybe he's feeling like there's some lack of confidence that he's taking it seriously this time or that he's going to be successful. I think it's reasonable that it's okay that both sides have emotions. It's not our job to place judgment on that, but let's talk through it. So I think that would be a really big learning opportunity. And I think something for us to consider is, hopefully we have been since the family is clearly involved, hopefully they have been engaged in the discharge planning process from the beginning. Why are we hearing about this on day 21? Why is this brand new info being presented to us? Are we maybe not asking the right questions of family or engaging conversations with them that this has become jarring information to us? And how do we move forward to ensure that there's ideally, hopefully less surprises like that in the future so that we can really support Bill and his whole family? It's when we're engaging in substance use treatment, yes, we usually have one specific client, but we're really helping heal a whole family. So I think that would be critical, is to evaluate, why is this brand new information? And it seems like, they're pretty confident in their decision. So they might have done some research. They might have talked to other people. Why is it that this is brand new info to us? And what can we do to make sure that we minimize that moving forward? Not that we can't make changes, but that it becomes less of a surprise so that we can really support a smooth and transparent process for Bill.
Yeah, this also might call for an apology from staff, right? So we talked about that on the do's and don'ts. Again, just taking the emotion out of it, being really open, non-judgmental, apologizing for any miscommunication is, again, only going to help foster a better situation for the client going forward.
Absolutely. Whew, okay, there's a lot of information. We really hope this training was helpful to you as you kind of consider how to help block AMA in your facility. Like we've said before, obviously it is not 100% avoidable. You shouldn't decline people from leaving your treatment unless they're court ordered, which of course is an entirely different scenario. But hopefully we've given you some tools to help reduce it at your facility as much as possible that's within your control. So as we wrap up today's session, just some things to consider. What are the ways that you can improve your culture at your facility to lower the risk of clients going AMA? From the very beginning, we talked about what's in your control and what's not. So let's kind of see what are some ways that we can improve. Are there any cosmetic changes that can be made to the environment for clients to reduce the risk of someone leaving, or just some easy changes, kind of low bearing fruit? Can we extend outdoor time? Can we provide some flexibility with the phones? Where are some of those kind of easy, small changes that can be made that can really have a high impact? And then what are some key takeaways from today's training that you want to implement at your facility or in your program to help prevent AMAs? And how can we talk about that as a team? This should be everyone's goal, whether you're a marketer, whether you're a facility director, whether you're a therapist, a nurse, maintenance. We all have a role to play to help reduce AMAs. So, what can be done? What can we take away from this that's an area for us to grow in? And what are some solutions that we've discussed that you can partake in? So we hope this was helpful and informative. Thank you so much for joining us today on this training. As always, at Hatch, we are here to help and guide and support you all. And we hope you have a great rest of your day. And thank you so much for tuning in. Bye, everybody.
Bye, everyone. Thank you.